Hello, everyone. Thank you so much for having me today. It is truly an honor to be here. Today, we're going to talk about Hirschsprung's disease and anorectal malformation. Our objectives are to become familiar with Hirschsprung's disease and anorectal malformation, to review the postoperative surgical and functional complications in children with Hirschsprung's disease and anorectal malformation, and to illustrate the workup of children with these disease processes who experience late postoperative complications. Hirschsprung's disease and anorectal malformations share abnormal embryonic development. They both require a surgical correction, and they both have similar GI sequelae and complications, such as constipation and fecal incontinence that significantly affect quality of life. We know that altered bowel function significantly affects quality of life. It can diminish physical activity, emotional well-being, psychological and social functioning, and contributes to parental anxiety and depression. Let's first begin with a discussion of Hirschsprung's disease. This is a complex, multigenetic disease that is characterized by the absence of ganglion cells within the intestinal nervous system. This begins at the sphincters and then can become progressively extend proximately in the intestine. This segment, also known as the aganglionic segment, causes a functional obstruction because during peristalsis it does not open and hence causes a functional obstruction. The incidence of Hirschsprung's disease ranges from 1 in 5,000 to 1 in 10,000. In 70% of the patients, it is non-syndromic or isolated, and in 30%, it is associated with a chromosomal or congenital anomaly. In 80%, it is short segment, and in 3 to 10%, it includes the entire colon. The clinical symptoms vary based on age at presentation and in the extent of the aganglionic segment. Infants and neonates present with bilious vomiting, delayed passage of meconium, significant enterocolitis, and can possibly present with perforation of their bowel wall. However, older children can present with refractory constipation or incontinence, malnutrition, and significant abdominal distension. Endorectal pull-through surgery is the mainstay of surgical intervention for patients with Hirschsprung's disease. The three common types are Swenson, Suave, and Duhamel. It's important to know which type of surgery there was, as the complications can vary between them. Typically, in patients less than 6 months of age, we do a primary pull-through surgery. In patients greater than 6 months of age, or those with a dilated bowel, the surgeons do a diversion ostomy, which is later followed through by a pull-through surgery. The common misnomer in pediatrics is that once the surgery is done, the child is presumed to be fixed. However, we know that is not the case. Hence, we always say, once a Hirschsprung's, always a Hirschsprung's. This connotes the true chronicity of this disease process. The history, the symptoms for the patient, and the follow-up all impact significantly the late postoperative complications and the sequelae. Thus, as a patient or a parent of a patient, it's really important to know how the child clinically presented or the type of surgery that they have had. What were the immediate postoperative complications? Or what are the symptoms of this obstruction that they're having? They're having recurrent enterocolitis, fecal disimpactions, incontinence. All patients need chronic long-term follow-up, even if they are doing clinically well. And ideally, they should be followed in a multidisciplinary clinic with a surgeon, a gastroenterologist, and ancillary staff that have the experience and see patients with Hirschsprung's disease. What are some of the late postoperative complications? These can be divided into two kinds: obstructive symptoms, which can present in up to 30% of patients, which includes constipation, enterocolitis, abdominal distension, fecal impactions, failure to thrive, and vomiting. And also, the second is the fecal incontinence. This can present in up to 74% of patients. How do we evaluate a patient who has Hirschsprung's disease, has undergone surgical intervention, but now presents with symptoms of either obstruction or with fecal incontinence? It is very important to have a very stepwise, systematic approach to patients. Most importantly, we have to look at anatomy and histopathology. In the following slides, we will go through such an evaluation. Of most important one is the anatomy. We have to make sure that the patients do not have a mechanical cause for some of their symptoms. These include a stricture, stenosis, a twist, and other complications. It's also very important to look at the integrity of the anorectum, looking specifically at the muscle complex, if it's damaged or not, and to look at the dentate line. The dentate line is important because it can differentiate between solids, liquids, and gas. This can be done with examination under anesthesia or contrast enema as well. In the following slide is an example of some etiologies of mechanical issues: bowel torsion, stricture, or suave cuff stenosis. When these are found on a contrast enema or examination under anesthesia, the patient is always referred to surgery for surgical revision and evaluation. In the following slide, these two pictures show a compromised anal sphincter complex, meaning that the external sphincter and likely the internal sphincter are both damaged, and this can then lead to incontinence and significant problems. In the following two pictures displayed below, there's damage to the dentate line. Again, if the dentate line is damaged, then the patient has difficulty differentiating between solid stool, liquid stool, and gas, and this in itself can lead to significant incontinence. After the anatomical abnormalities are looked into, it's also very important in the meantime to evaluate the histology. It's very important to review the original biopsy by an experienced pathologist to make sure that we are not missing a transition zone or a residual aganglionosis. Because if these two are identified, then the patient will need a redo operation to ensure that all of the affected parts with Hirschsprung's disease are adequately removed. Once the anatomical and the histopathological abnormalities are taken care of, then we can move forward with a functional evaluation of transit and the motility of the anorectum and the colon. So how is this done? To evaluate for anorectal dysfunction, we can do anorectal manometry. It is displayed in the picture below. It's a small catheter with a balloon at its distal end that is introduced through the rectum. And in patients with Hirschsprung's disease, this is important because it can measure the intra-anal pressures. As we know, this intra-anal pressures, this internal anal sphincter pressures, if they are high, then the surgeon or the gastroenterologist, depending on the patient and their symptoms, may administer internal anal sphincter Botox to decrease these pressures and decrease obstructive episodes. It's also important because we can also identify if a patient has pelvic floor dysfunction. We can also look to see if there's withholding behavior and also evaluate sensation. To evaluate for colonic dysmotility, we can do a test called colonic manometry. This is when a small catheter during an endoscopy and colonoscopy is inserted through the colon, and the next day a colonic motility study is performed. During the study, we measure the specific pressures in the colon after administration of medication. We can tell if part of the colon or total colon is not working, or if there's colonic hyperactivity, or if there are contractions, are they traveling all the way to the anal verge and therefore causing incontinence? These studies combined, given the clinical picture and the patient's examination and other ancillary studies, will help us then determine the type of treatment plan specific for that patient. Will the patient benefit from oral medications or rectal medications, or do they need other surgical interventions, such as a Malone or a cecostomy for providing for antegrade colonic enemas? Now let's move forward with discussion of the anorectal malformations. Incidence of anorectal malformations ranges from 1 in 5,000, and it is slightly more common in males. The following diagram displays the type and frequency of most common anorectal malformations in males and females. Rectourethral fistula is the most common one that is observed in males. Vestibular fistula is the most common one that is displayed in females. If an anal stenosis or rectal atresia is found, it is very important to be able to rule out Currarino's triad, as 1% of these patients can have sacral abnormalities, anal stenosis, and a presacral mass. There's also other complex and rare variants as well, such as bladder exstrophy and cloacal exstrophy. Surgery is the mainstay of treatment. There are multiple different types of surgical options. The type of surgery depends on the complexity of the malformation. Perineal or cutback anoplasty could be done for more simple malformations. Primary posterior sagittal anorectoplasty, such as PSARP, for those simple malformations as well. Those who have complex malformations may need a primary colostomy that is later followed by a PSARP. It should be performed by an experienced surgeon, as it can significantly influence the surgical and the clinical outcomes for the patient. Some of the late postoperative complications seen in patients with anorectal malformations include fecal incontinence and constipation, seen in nearly 80% of patients, urinary incontinence, and also significant sexual dysfunction. Patients who have simple malformations are more likely to have constipation and develop megarectus sigmoid, which we will discuss in the next slide. But those with complex malformations are more likely to have fecal incontinence and less likely to be continent. It's very important to aggressively control constipation in children with especially low malformations or simple anorectal malformations, as this can lead to overflow, fecal incontinence, recurrent fecal impactions, colonic and rectosigmoid dilation, leading to megarectus sigmoid. It's very important to aggressively monitor them and place them on correct medications to adequately control colonic emptying and decompress this colon. In your meetings with different surgeons and consultations, patients may also hear about specific predictors of bowel control. Some of the surgical predictors of bowel control are commonly the type of anorectal malformation, the presence of spinal anomalies, or the sacral integrity. Then this information is used to determine if oral or rectal medication is more appropriate for the patient. It's also important to note that there's functional predictors of bowel control, and those include the anorectal and the colonic neuromuscular function as tested by anorectal and colonic motility. When we evaluate a child with anorectal malformation who's had surgery but yet presents with symptoms, it's very important to make sure that they have completed their bacterial screen. They've had a cardiac echo, renal ultrasound, and an MRI of the spine and pelvis to ensure that there's no tethered cord or a presacral mass. It's very important to do an examination under anesthesia to ensure that there's not an anastomotic stricture, and to evaluate the placement of the anus, and to also see if the anal muscles are damaged or not. Again, the integrity of the colon is usually measured with a contrast enema. Once these are performed, it can identify if a patient has any mucosal prolapse as seen in the picture here, which can indicate a possible misplaced anus, again seen in the picture on the right. These can significantly impact patients' bowel outcomes and also need redo surgery. Once the anatomical abnormalities have been addressed, then we can move forward with a functional evaluation of transit and motility. Similar to patients with Hirschsprung disease, we can do anorectal manometry. And in patients with anorectal malformations, we can see if the patient has any abnormalities of their intraanal pressures. Commonly, patients have low intraanal pressures, or they may have findings that suggest a neuropathy, either intrinsic or that is something that's of spinal origin. They may also have abnormal voluntary properties, such as ability to squeeze or to feel the balloon, and also pelvic floor dysfunction. When we look for colonic dysmotility in patients with anorectal malformations, some of them may have total or segmental colonic dysmotility, Others may have contractions that go all the way to the anal canal, and thus that is what's causing their incontinence, or even colonic hyperactivity. And once again, once all of the anatomic and functional information is put together, then we can determine the type of medical therapy that is needed to control their symptoms. Do they need surgical intervention? Do they need medical intervention for better bowel control? And does that include oral medications, rectal medications, or surgical treatment with antegrade enemas? In summary, abnormal embryologic development of the intestine results in Hirschsprung's disease and anorectal malformations. Surgical intervention is the mainstay of treatment, which necessitates lifelong monitoring for early and late complications. Aberrations in anorectal and colonic anatomy and neuromuscular function affect defecation dynamics in children with Hirschsprung's disease and anorectal malformations. Diligent follow-up, recognition of complications, timely workup is necessary to prevent significant morbidity and mortality. Thank you, and it was such a pleasure to be here today.